Okay, good day everyone. Our topic for today is antidiabetic medications and the pathophysiology of diabetes. We'll have a review on the antidiabetic medications, specifically the names, its classification, types of insulin, most importantly, the mechanisms of actions of antidiabetic medications. And also we will describe how our body fails to regulate glucose level, leading to hyperglycemia due to insufficient insulin production. And at the end of this presentation, again, a short quiz will be provided as part of your participation. And for any queries or clarification, you can always visit us at Academic Affairs and Training. Okay, to start with, I want to present to you the different classifications of antidiabetic medications. Like we have the sulfonylureas, we also have the thiazolidinediones or the TCD, we have the bigonides, alpha-glucosidase inhibitors. We also have the DPP-4 inhibitor or dipeptidylpeptidase 4 inhibitor. We have the SGLT2 inhibitor or the sodium glucose cotransporter 2. We also have the non-insulin injectable agents like the GLP-1 and the amylin mimetic. We have the meglitinides or the glinides. And we also have, of course, the insulin. And I'll be presenting you some examples and mechanisms of actions as we go on with the presentation. Okay, now moving on to the definition of terms. So diabetes mellitus is defined as chronic medical condition. So when we say chronic, this is an illness persisting for a long time or constantly recurring. Now it is a medical condition wherein our body has problem regulating our blood sugar level. Now this occurs because the body may not produce insulin, or the body does not produce enough insulin, or the cells don't respond properly to insulin, or it could be both. The body does not produce enough insulin and the cells don't respond properly to insulin. Then another term is insulin, and this is defined as a hormone produced in the pancreas by the islets of Langerhans, which regulates the amount of glucose in the blood. Okay, now moving on to the next slide. So this is pancreas. This is an illustration on how the pancreas works. First, let's imagine after eating, the blood glucose in our body will increase. So we term that one as hyperglycemia. And hyperglycemia is the one that stimulates the pancreatic beta cells to secrete insulin. And insulin is the key to lowering the blood glucose level in our body. Now, how does insulin works? So first, the insulin increases the glucose uptake or the consumptions by the cell. So the insulin helps the muscle cells, the fat cells, the liver cells take in glucose from the blood. Now the glucose is then used for energy, and the excess glucose is converted into glycogen for storage in the liver and in the muscles. And this process is called glycogenesis. Then it inhibits or it prevents the liver from making and releasing more glucose. So we term this one as gluconeogenesis and glycogenolysis. So in summary, the function of the insulin, first, it increases the glucose uptake by the cells. It stimulates glycogenesis and it inhibits gluconeogenesis and glycogenolysis. Okay, now what about when there is no food intake or in between meals or when we are fasting? So what happens is there is hypoglycemia, so the blood glucose drops. So hypoglycemia stimulates the pancreatic alpha cells this time to secrete glucagon, and glucagon is responsible in raising the blood glucose level in our body. Now how does glucagon works? So there are two metabolic processes. The first one is the stored glucose in the liver in the form of glycogen will break down into glucose and it will be released in the bloodstream. And we call this one as glycogenolysis. The second one is the liver is stimulated to produce new glucose from a non-carbohydrate sources like the amino acid and the lactic acid. And we term this one as gluconeogenesis. So the glucagon works by glycogenolysis and gluconeogenesis. Okay, now moving on to another illustration, we have type 1 diabetes. Again, let's imagine after eating, there is hyperglycemia, which stimulates the pancreas, specifically the beta cells, to produce insulin. This time, there is no insulin produced by the beta cells because the beta cells is destroyed by the immune system. So the glucose cannot enter the cells because there's no key, which is the insulin. So the glucose cannot enter into the cells, so they stays in the bloodstream. So the cells are starved of energy despite the high blood glucose level. So type 1 diabetes really needs insulin. Now, in type 1 diabetes, there is a metabolic processes that increases the FFAs or the free fatty acid. When the FFAs increase, the liver converts them into ketone bodies. Now, if this condition persists, the increase in the ketone bodies will lead to ketosis and metabolic acidosis. So the DKA sets in. Okay, moving on to the third illustration, we have type 2 diabetes. Again, let us imagine after eating, the blood sugar level in our body will rise. So we term this one as hyperglycemia. And hyperglycemia is the one that stimulates the pancreas, specifically the beta cells, to produce insulin. This time, in type 2 diabetes, insulin is produced, but not enough or the cell don't respond well to insulin. There is resistance. Now, the pancreas will try to produce more and more insulin to compensate, but eventually the beta cells get exhausted, leading to high blood sugar level and low insulin efficiency. Now, what happens if high blood sugar level persists? This can cause further damage to the beta cells, and we term this one as glucotoxicity, and there is increase in insulin resistance. Now, there are factors that contributes to the occurrence of insulin resistance. So the first one is obesity, specifically the visceral fat. This is in our abdomen. Adipose tissue releases pro-anti-inflammatory cytokines and free fatty acids, which interferes with the insulin signaling. Second, chronic inflammation. This disrupts insulin receptor and signaling pathways. Then we have the third one is lipid accumulation in the liver and in the muscles. So this leads to lipotoxicity, which impairs insulin receptor signaling. Then we have the fourth one is the sedentary lifestyle, which reduces the glucose uptake by the muscles and it worsens insulin sensitivity. Then we have genetic predisposition. For some individuals, they are more genetically prone to insulin resistance. And finally, we have hyperinsulinemia, wherein too much insulin can also affect insulin receptors. Okay, now moving on to the types of diabetes. In summary, type 1 diabetes is an autoimmune condition. It means that the immune system attacks the insulin-producing cells in the pancreas, usually develops in children, young adults, and need a lifelong insulin therapy. Type 2 diabetes, the body becomes resistant to insulin and doesn't produce enough insulin. More common in adults, but increasingly seen in children. This is linked to lifestyle factors like inactivity, obesity, and diet. Often managed with diet, exercise, oral medications, and sometimes with insulin. Third is the gestational diabetes. This occurs during pregnancy and usually goes away after birth. Increases the risk of developing type 2 diabetes. Okay, now let's move on to anti-diabetic medication examples. Let's start with the sulfonylureas. Here we have the prefix gly and gli. So an example is glyburide, glimepiride, and glipizide. Next, we have the thiazolidinediones or the TCD. The suffix here is glitazone. So an example, we have pioglitazone, rosiglitazone. Then, of course, we have the biguanides. An example here is the metformin. And then we have the alpha-glucosidase inhibitor. Example is the acarbose, miglitol, and paglivose. Now, moving on to miglitinides. So here we have a suffix glinide. So an example, we have repaglinide and natiglinide. Then we have the GLP-1 receptor agonist. An example, we have the liraglutide, exenatide. And then we have the DPP-4 inhibitor. Here we have the suffix gliptin. So an example is sitagliptin and vildagliptin. The next is the SGL2 inhibitor. So again, we have the suffix gliflozin. So example, we have canagliflozin and dapagliflozin. Okay, then we have a nursing consideration on our client taking metformin or the glucophage. So we have to give this patient teaching. So take the medication with food to avoid stomach upset. Avoid alcohol because this increases the risk for lactic acidosis. And we have to inform the healthcare provider before surgery or before any radiologic procedure with IV contrast. So we need to withhold the metformin for 24 to 48 hours before and after due to the risk of acute renal failure and lactic acidosis. Okay, moving on to the types of insulin. So we have the types, the generic, and the brand name. The onset, or this is the time the insulin starts working. We have the peak, the time insulin works the hardest. The duration, how long the insulin stays active. So to start with, we have rapid-acting insulin like the Lispro, Aspart, and Glulicin. So 10 to 30 minutes the onset, 30 minutes to 3 hours for the peak, and 3 to 5 hours for the duration. Now, short-acting, we have the regular insulin, around 30 to 60 minutes for the onset, 2 to 5 hours for the peak, and 5 to 8 hours for the duration. Next, we have the intermediate acting. We have the NPH insulin. This is the only insulin that is cloudy, and then 1 to 2 hours for the onset, 4 to 12 hours for the peak, and 12 to 18 hours for the duration. Then we have the long-acting insulin. We have the glargine and the detemir. So 1 to 2 hours for the onset, minimal peak, and the duration is up to 24 hours or more. Now, please review your hospital protocol as to the administration of insulin, which can and cannot be given via IV, and which insulin can be mixed with other insulin. Antidiabetic medications work through several main mechanisms of action to lower blood glucose level, so they can be categorized based on how they affect insulin glucose production or glucose absorption. So for the mechanisms of action starts with, number one, it increases insulin secretion. So this drug stimulates the pancreas to release more insulin. So example, we have the sulfonylureas, meglitinides, the GLP-1 agonists, and the DPP-4 inhibitors. Second, it delays carbohydrate absorption. So this medication slows the digestion and absorption of carbohydrates in the intestine. So an example, we have alpha-glucosidase inhibitor. The third one is it increases insulin sensitivity. So this medication improves the body response to insulin, especially in the muscles and fat. So an example, we have the biconide and the thiazolidine. Then the fourth one is it increases renal glucose excretion. Now, this medication promotes glucose loss in the urine by blocking reabsorption in the kidney. So, an example is the SGLT2 inhibitor. The fifth one is it decreases hepatic glucose production. So, this medication reduces the amount of glucose produced by the liver. So, an example here, we have the biconide and the GLP-1 receptor. Then, finally, it mimic or it inhibits incretin. Now, this affects incretin hormones, which increases insulin and decreases glucagon in response to meals. So, an example, we have the GLP-1 receptor agonist and the DPP-4 inhibitor. Okay, now let's move on to our final slide. So, we have diabetes management. To start with, lifestyle modification. Under this, we have diet, so we have to consider low glycemic index food, calorie control, especially for overweight and obese client, balanced macronutrients, complex carbs, lean protein, and healthy fats, then avoid sugary drinks and refined carbs. Now, for exercise, we need to do this one at least 150 minutes per week, and brisk walking will be okay. Resistance training 2 to 3 times a week, because this increases insulin sensitivity and promotes weight loss. Then we also have weight management. So we need to set a goal for weight management, like example 10%. Then next we have pharmacologic treatment. For this, regular consultation with our physician is needed and to follow prescribed medication. Then next we have monitoring. Under this, we have glycemic monitoring and complication screening. Under glycemic monitoring, we need to monitor our A1C every 3 to 6 months and to set a goal that A1C must be less than 7%. Now, self-monitoring of blood glucose if the patient is on insulin, also sulfonylureas. And then for complication of screening, so annually we have to check for retinopathy. So we need eye exam. Nephropathy, so urine albumin creatinine ratio must be checked. And then neuropathy, so we have to check for our foot, and then lipid profile and blood pressure. Next, we have management of comorbidities. So we have to check for hypertension, dyslipidemia, cardiovascular diseases, as well as kidney diseases. Then finally, patient education and support. We have to teach our patient about hypoglycemia, medications, food care, smoking cessation, and encourage them self-management education.